This is a short panel discussion. We'll adapt the duration to the need to interact. So can I invite people in the hall to ask questions or think about them while I will ask the presenters to just give us the one message from their talk today. So can we start with Professor Fatemi? One message from your talk today.
So I think it's the same message as we have heard yesterday on the luteal phase. If you can individualize the luteal phase, we should also individualize the follicular phase. When we speak about individualization, it is important to realize it's not one size fits all. When you look back to nature, you see that you have an increase of FSH in the follicular phase in the beginning, and you have a drop towards the end simply because you have less FSH receptors. And I think this needs to be replicated. Now, the question is how much FSH is required, and I think through these studies that we have conducted and studies which are going to be conducted in the near future, we will understand what is the best dose for that particular patient. But extremely important to realize that the last 2 to 3 days of stimulation, the patient barely has FSH receptors. This is why we don't need a huge amount of FSH, especially towards the end of the follicular phase.
Thank you. Professor Polizos, one message from today. If you don't mind, maybe switch on the mic. We're all...
Yes, my apologies.
Thank you, no issues.
So I would agree a lot with Human, and for me, the message I would like to pass is that LH is a hormone which nature has selected to be part of the follicular phase. And Human really clearly says that in the end of the follicular phase, you have more LH receptors. What I want the people to understand is that LH deficiency is not what we used to think. It's not only an impaired production, it can be an impaired action. And there are several patients that they do need the LH. It cannot be that the follicular phase, it's only FSH dependent.
Thank you very much. Professor Anderson, your message today.
Thanks very much. Yeah, so I think the message I'd like to say is there are exciting times ahead for both understanding the etiology and potential novel treatments in POI. They're not immediately around the corner for clinical practice, but they will come, especially for those of us, or those of you in the audience who are rather younger than I am.
Thank you. Professor Velasco, how does the future look like?
Well, I don't know, but I think we have to have in mind two things. First of all is that we have to listen to patients. Just because we think it's good for them, they may not like it. So we have to listen to patient demands. And I think this is very important, especially in this new era that patients are going to change and we have to adapt to them. Just because it's possible doesn't mean that we have to do it. And the example always, I think, for me is the way that you can buy a book. You can order through Amazon, you have it tomorrow, but I prefer to go to a bookstore and hang around. But again, if you want to have it at home tomorrow, you can do it. So we have to listen to them, see what they prefer, and then adapt to that. And the second message, I think, is a concept that we will see more and more, and is rather than bringing patients to the clinic, I think we have to bring the clinic to the patient at home. And we have to deliver this concept because more and more patients will try to avoid coming to the offices. They will just come for things that have to be done in the office, but anything that can be done at home, like we do with any other thing, I'm sure it will be done.
Thank you. The first question from the audience, Professor Dove, please.
Thank you. First of all, congratulations to all speakers for excellent presentations. So thank you all. This was very, very, very good. I have one general question which is actually open to all those who wish to respond. It's on AI, as Professor Velasco was talking about it. I think we all know it's the kind of new buzzword, and we see in many conferences, especially in the embryology field, abstracts and publications on AI, essentially scratching the surface, having promising data, but ultimately the truth is in validation and added value in clinical practice. So I wonder if the panel could comment on what they see as the right way forward to yet prevent another failure in our discipline, where we hope for innovation and we try something, then it doesn't work, it's not validated and it disappears, right? And I think, again, here with AI, there is a significant risk that this may happen. So I would like to see or hear the views of the panel on what the right approach is to build AI or to develop AI in the context of assisted reproduction or reproductive medicine overall, and whether, how they look at the potential in embryology and beyond also in clinical decision-making.
Well, if I may start, I think, as you said, the risk for failure is there. And the problem with many things in our field is the overpromise. We want to be the first. We want to be the first to use something. And if it doesn't really work 100%, then we just abandon it. And sometimes it's not that simple. The truth is that if you go to meetings today, you go to ASRM or probably sure in ESRA in a few months, the number of publications regarding AI is increasing dramatically. Take the last issue of FNS, for instance, or any journal, and there are nice editorials. There's an editorial by Bart Fauser. There's an editorial commenting on a paper on AI on clinical decision-making. So this is something that we will read continuously more and more. The problem is that still the predictive value of these algorithms is still not enough. It's probably, it's a good guess. That's as good as it is today. So I think that we should limit, and this is a very delicate word, we should limit ourselves in using things that could be promising but still do not deliver what we want. And the benefit here, and this is how I see things, I may be biased, but I think doctors in general, and allow me to say this, I'm part of the group, doctors have a huge ego. So we tend to think that a machine will never beat us. We will be always better than the machine. So this is going to help us in this sense, because we will adopt these algorithms once they really show that they work. Otherwise, we always want to be on top of the machine. So this is my personal comment.
If I may comment on that, so I look at what we do, again, going back to the cars, like a car. So you have the gearbox, you have the engine, you have the electronics, you have the tires, so everything needs to be balanced and being fully synchronized with each other. Now, the problem I see with AI is most of us are having a tunnel view. If you take a look at an embryologist, he or she is looking to the embryology. If you take a look at a clinician, he or she is looking at the clinical data. If you look at a genetician, he or she is looking at what he or she is doing in the genetic lab. But we are not having a holistic approach. And with AI, imagine you are collecting data from one and you draw any conclusions with that. You are neglecting all the other parts. So it is important to have a holistic approach once you develop AI, because if you go on the wrong path, and that's what you mentioned, you might go completely in the wrong path, because you're feeding the wrong data into the system, and the system is giving a wrong conclusion on what needs to be done. And I think this is a mistake which we are currently doing. So we publish a lot on AI, doing this, and on every congress today, everyone is speaking on AI. But first, we need to understand the basics and understand that the egg that we have in the lab came through an ovarian stimulation. How did we do this stimulation? How was the final maturation? What was the systemic circulation? What was the endocrine profile? Demographics of the patients, everyone is different. And I think it is now a crucial point that we realize we need to have a holistic approach and not a tunnel view on every aspect, looking to an embryo, division pattern, dynamics, but these came through a certain stimulation. So I think we need to have really a holistic approach in the AI development.
Okay, somebody wants to say something? I'll reserve my comments last.
Yes, may I?
Please.
I agree also. I would like to ask a question against this question. What has been the greater success in IVF or in the lab the last 25 years? Because we're talking about all new AI, we're talking about genetics. We have seen the endometrial receptivity assays that they were the super hop in the beginning, but then they became the hype, and I don't know if we are using it in the end. I would be a little more reserved. Of course, it's very important using technology. Technology is what we need, and we use it in our labs. But I would agree with Human that we have a lot of other variables and parameters that are related to patients' characteristics, rather than checking the embryos and looking at the embryos 2, 3 more divisions, and whether this can predict a better implantation or how we will do it. We need a randomized trial. We know with endometrial receptivity assays was the same. Randomized trial came and it was not as expected. So I don't know if in the end using AI to select or to treat your patients would be better than the doctors. I would also agree with Juancho that yes, we have a big ego and we have to put it a little aside. But I think it should be a mixture at the end.
Professor Anderson, do you want to make a comment on the question?
Yeah, thanks. I think there's some very sensible comments made already by the audience. Sorry, by the speakers. Juancho makes a good point about this is all about personalities, and unfortunately, you need people who want to promote themselves, to promote good ideas and produce novel ideas that are exciting, and innovation derives from that. That's a sort of part and parcel of sort of how this works, and it definitely has a downside. And I guess we need to just, pick up what Nicholas says, is that ultimately, what invariably happens about these things, there's an overpromise, there's then a counter swing against that, and then if it's got real value, the good trials come out and it finds its place. And that's an inevitable part of scientific advances. I guess what we need to try and be careful against is that initial overswing being too ridiculously positive because a couple of famous, well-known people in the field promote it. And there is sort of we must sort of strive against the cult of personality in medicine as in politics. Ultimately, the truth will out, and we just need to not have had too many casualties on the way by people over-promising what technology may or may not offer. And Human, I absolutely agree with you. I mean, ultimately, what we would like to be able to do is be able to predict right through from seeing the patient the first time in the clinic what the right treatment will be and how successful that treatment will be. And that remains a real holy grail that we need to try and think about integrating the various steps, as you say. I think that's really a valuable way forward. I guess I'm slightly skeptical as to sort of seeing that in reality in the foreseeable future, but it does still remains a holy grail at the end of the day.
Thank you. Before the question from the audience, I might just say that maybe we need a different approach to understanding and defining what we're talking about, because there are two separate elements here. One, if you look at human life, if we talk about AI, now it's like saying that a child is being born and without going to school, it's going to be the next Niels Bohr, yes? And that is impossible. So the first step is understanding how technology can help comprehend human action. So the deep learning, which is the first step in any artificial learning, that process needs to be defined. And who's going to teach a computer what is the perfect way to look after a human being or an embryo to develop in the laboratory, but scientifically proven processes that give guaranteed results? So do we have the current approach or the current knowledge to say the ideal way that an embryo should develop from point 0 to day 5 or day 6 in an incubator is this? And we do have that knowledge, but the pre-oocyte intervention is so variable that you do not know how many oocytes and embryos will develop in that matter. So I think we have to define ourselves, what do we want to teach the machine, and make sure that we input that first, because that's what happened with Deep Blue. Deep Blue analyzed millions and millions and trillions of mutations to say, if my opponent does this, I have to do that to counteract. So if we cannot teach the machines, because one study says you have to do that, and one study says you have to do that, then we have a big dilemma. So I think coming down with our expectations and promises and starting from the grassroots and defining what can we safely teach a computer today, I think will be the first step that proves the principle. That's a proof of principle that we can teach a machine to learn a process.
I couldn't agree more, but my feeling is that this is like a train, and the train already left. So it's up to us to get the train or not.
To run. Thank you. Question from the audience.
Yeah, it's more of a comment. So I was asked to participate in this debate in JARC on the use of AI. And I was randomly assigned to argue or provide arguments against the premature use of AI. And so I named my part, Babies Not Gadgets, because I think one thing that happens is we have these gadgets and the use of continuous camera monitoring for embryos was one of those examples where it looked great and everybody loved it. But the question is, with every innovation that we add, it also increases the cost of every cycle. And it has this sort of risk that IVF one day will be a treatment for some privileged few who can afford this package with all these big gadgets and things. And what we really want to do is help patients have babies. And so I think all these innovations have the risk of making IVF a more privileged and elitist treatment. And so I think before something like that gets implemented, which raises the cost of every cycle, we have to first prove that it actually increases the number of babies. That's just a thought about the use of AI, because I think we all love it, because, you know, like we love to see models and numbers and, you know, films and you know, everything. Like, we're all technologically loving people. But if it just increases the cost without increasing live birth rates, then it might actually be detrimental in the end.
Yes, there is a sweet spot there between using technology to promote a service as a competition versus a truly value-added service to the patient, without a doubt. Anything else? I do have some specific questions, if that's okay. Maybe I'd like to ask the first two speakers, can they talk something about, should we change how we investigate our patients before IVF, considering the need to individualize our treatments? So what do you see a new algorithm to investigate patients? Would you add something to it? Would you dispose of something? Yeah, just a few words maybe. Okay, should I go to the next question? Oh. Sorry, I can see that. Right.
No, but we can start. We can talk about this. So for me, if I may, I don't know. I think it has to be practical also, because we're running big clinics. If you have 3,000 cycles or 4,000 cycles, then in the end you have to put to work like you work in the lab. You need to have SOPs and you have to work. I don't know the way that it's working, the system, by the pre-screening of the patients, is efficient from my point of view in most of the clinics. That's why we have very good results. Results in most of the clinics are good. Of course, there would be room of optimizing, but I think we need more evidence, because sometimes we jump on the train too early and then we are going on the wrong track, and then we need someone who should change the track and put us to the good track. So I don't know, sometimes we jump too much on the early ideas, but I think the way that we're doing our work for the moment, we may need to individualize a little more, but the new ovarian reserve markers that we have, and possibly new biomarkers that will come, will put us in the right track. And we need to understand, as Roman is saying, is that each patient is different. You cannot block them and put them in the same bag. Individualizing is very important, and I think we have the means for the moment to individualize.
Thank you. First, tell me one single thing that you've introduced in your clinical practice in the last, let's say, 2 or 3 years that made a difference.
You know, one thing which is very interesting to me personally is the fact that you cannot anticipate with AMH, a reliable measured AMH, a response of a patient. And you know, we see that on regular basis, that you have patients with a certain AMH and you just harvest a different number of eggs than you would expect. Of course, we published there is up to 50% intra and intercycle variation of AMH, but still that doesn't answer the question that you have a patient with an AMH of, let's say, 0.4, 0.5 nanogram per ml, and you harvest, let's say, 4 or 5 eggs, and you have a patient with an AMH of 1.6, 1.7, and you harvest only 2 or 3 eggs. So there is a lot of variations and a lot of things we still don't understand. And I think here, the basal systemic levels of FSH, but a more detailed assessment of these FSH levels would be interesting. I think we need to understand the cycle pattern of the patient. I think we need to understand what is the basal systemic FSH level of that patient. She might be a normal responder, but if her basal FSH levels are 8 or 9, this is to me elevated. Could be that this patient has problems with her FSH receptors. I think these are details which needs to be looked at in future studies to better understand and individualize the patient's response.
Thank you. I was intrigued and admired the paper that you presented this morning with measuring serum FSH in patients during stimulation. I'm not aware of any study that did the following. No, just the question comes now.
Yeah.
Use the pen, squirt the same amount that you will inject in a test tube, inject the patient, and measure the FSH level, and prove that every time the patient or what she injected correlates in some way to what circulates. So this is a study where before you administer, the patient has to put a drop or the amount in a test tube and it's sent to the laboratory. This is the FSH to be injected, and then measure the endogenous FSH and see a difference. Are you aware of any study like that?
You know, I was discussing with Professor Doge this morning during the break. I mean, even the big pharma companies, when they were developing all the drugs that we are using, of course, they have measured the systemic FSH levels. But to the best of my knowledge, I think they didn't look into the time when they have administered the FSH. They didn't look to the time they have measured the FSH, because you need to look to the pharmacodynamics of these drugs. When you administer, you have a certain absorption, you receive the peak, and then you have a drop. And I think this gap between the time you administer, between the time you measure, preferably the hours after your antagonist administration, to have a perfect understanding of how much FSH is present in systemic circulation. To the best of my knowledge, this has never been done, even in all the dose-finding studies which we are referring at today. And it's our task as clinicians to start looking more into detail how much systemic FSH is present and how much is required. If you ask me how much is required, my answer is I don't know. And I think these are studies that we need to conduct in future to understand. And it's not one systemic level would fit to all patients. I think every patient population would require different dose, but I think future studies need to address this.
Thank you.
See, but this is where technology again should help at the beginning of a cycle, because if we admit it, we work by trial and error. You see a patient, you see the AMH, AFC, maybe BMI, maybe ethnicity, and according to your experience, you guess and you start. And if you fail, then you change. And this is expensive because, again, this patient maybe spent 1,000 euros in medication, several consultations, she goes back to you, she has this feeling that she failed, we fail. If you could have, I'm just dreaming, but if we, and this is research, this is dreaming, but if we could have an algorithm that could put all the information that we cannot even update and that we could transmit to juniors because they were not exposed to thousands of patients like probably you have been, where you can maybe add, as Professor Conforti was mentioning yesterday, maybe the 5 most frequent mutations or polymorphisms of the receptors that the price may be similar to AMH. If you could put all that information in an algorithm, the first stimulation would be probably ideal. You would know if you need this amount of FSH, as Professor Fatemi is mentioning, if you need to add or not the age, according to Nico's lecture and what he read, if ethnicity in this particular patient is important, if this polymorphism is or is. So this is where we should aim, not continue just doing trial and error, because for us, it's our job, but for the patient, it's a long journey.
I couldn't agree more, but maybe pushing it forward. Why don't we, as we do a dummy transfer, let's say for patients that have cervical stenosis and so on, why don't we do a trial of FSH for 2 or 3 days and measure the FSH available or correlate with response and observe it?
But first we need to understand how much FSH is required.
Is needed, of course. Yeah.
And I think also when you speak about FSH, the next question would be when during the stimulation. You need to distinguish the first part of the follicular phase and the last part of the follicular phase. So most probably you would require different dosages. In the first part, you would require very less or no LH, but most probably towards the end, you would require more because you also have more LH receptors. So I think these are the details that we need to look at in future studies. And if you say it's a valid point, measure it, but then my next question would be, okay, how much is required? I don't know. So today we say maybe between 15 to 20, but really this is our feeling. Maybe it's not correct. And AI would help us to identify for those patients.
Thank you. More questions from the audience, please.
Can I just chip in there? I guess that goes back to the question we were just discussing before. AI can only use information that you can actually meaningfully derive and is actually going to be useful. It may be that some of these things that we think ought to be useful actually aren't very. And, basically, we're all struggling with the limited tools that we have available. Human, you mentioned the limitations of AMH as a particularly accurate predictor of number of eggs you achieve. Of course, there's huge variation here. And, you know, our tools are not as good as we would like to think that they are.
Thank you. Professor Velasco, I have one question related to telemedicine. Obviously, it is the future. Do you feel that, let's say, GDPR, I don't know, I'm sure the audience is familiar, at least in Europe, with the GDPR. How much do you feel we're exposed to a risk there? And do you think that we as a profession maybe should have certain documentation, appropriate legal backup and so on, to be able to discuss medical matters with patients? And obviously the question is open to all the speakers. Thank you.
Well, that's a good point, but I think if you can do bank transactions across the world and be exposed to severe risk of losing your properties, this is discussing about medical issues with a legal background, so that can be done. The only thing that has to be is implemented. And this is what it took for us. It took quite a lot of time to have these informed consents signed through the app, because we thought it was as simple as you upload the document, you sign it, and you give it back to me, but it's not that easy. But at the end of the day, this is a simple thing. Probably it's one of the simplest things that you can do. If you have a lawyer and you have an IT guy, you can do that. I mean, so that shouldn't be an issue. You are fully protected, and you comply with the requirements and legal requirements in your country. I mean, this is not a problem. We shouldn't have fear to those things. I think we have to aim higher and think that, you know, that maybe many things that we cannot even consider today, like monitoring the cycle or things that we are at the risk of someone getting the information, medical information across the nets, could be a risk. But honestly, I think there are so many ways of protecting that shouldn't be an issue. Thank you.